Evening. Today's topic, my request, interpreting labs in the ER. Okay, this is a very broad topic, and I was asked to give a quick short talk on this. Okay, when patients are admitted, obviously you're following the history and the physical, and you're evaluating, why the patient is in the emergency room and if they need to be admitted, and the lab tests are going to help you figure out what's going on. So for the purposes of this talk, I'm going to talk about patients who are admitted. So if a patient is sick enough to be admitted to the hospital, they're going to get blood work. You're not going to admit a patient without blood work. So what is ordered? CBC, either a basic metabolic or a comprehensive metabolic profile, possibly a troponin, and possibly a urinalysis. Okay, these are the basic things that are ordered. Now, depending on why else somebody's there, if somebody is abdominal pain, especially epigastric pain, you're concerned about acute pancreatitis, you may order a lipase. If somebody you're considering a pulmonary embolism and you want to stratify their likelihood, you may order a D-dimer. So there are other things you're going to get. These are the major, the CBC and the chemistry. Let's talk about the CBC. So you have the hemoglobin, the hematocrit, the white count, the differential, and the platelet count. So you need to see why the patient's admitted. It's hard to interpret this without knowing why the patient's coming in. Something that's important is if you have old labs to compare them to. So if a patient is anemic, then there are a lot of causes. Now, obviously, if somebody comes in with the GI bleed, the hemoglobin is very important, but the blood count's in transit. So it could be going down, as you're getting the blood. And it's good to kind of know the patient's baseline. So if somebody's anemic, you could basically, there are three major causes of anemia: bleeding, hemolysis, and some type of bone marrow problem. This is not a lecture on anemia, but you could break anemia into these three categories. If somebody's actively bleeding, you need to figure out where they're bleeding from. Most common source is the GI tract. You may have to heme test the stools. Hemolysis we don't see as commonly, but you're going to see stuff from the peripheral smear that might be indicative of hemolysis. And there's certain blood tests like an LDH and a haptoglobin that could be abnormal with hemolysis, as well as an indirect bilirubin. Bone marrow failure could cause a slew of abnormalities. It could be due to medications, it could be iron deficiency, it could be a megaloblastic anemia, and old hemoglobin is somewhat helpful here. But basically, what I like to teach, there's a mnemonic for anemia. It's called CRIPS. I learned this as an intern. So C is the CBC, R is the repeat count, I are the indices, P is the peripheral smear, P is the platelet count, and S is stool. So if you're evaluating a patient with anemia, you need to think of that. The retic counts. If you're bleeding or you're hemolyzing, the retic count will be elevated. If you have a marrow problem, it will be low. The indices, the MCV. If your MCV is high, it's either due to a lot of reticulocytes from hemolysis or bleeding, or they have a hemolytic anemia. The peripheral smear could be helpful. Now they do not have interns and residents looking at peripheral smears. You're stuck in the ER, you don't have time to go up to the lab. They have different lab regulations. It's a different world, but you still have to understand that peripheral smear will help you in a patient with anemia. Platelet count, self-explanatory, and it's always good to see if the patient's stools are heme positive or not. Now, more often, they do fit tests or they send the stools out to get heme tested. It used to be part of a physical exam. That's anemia. Okay, now if somebody's sick, they could have anemia, chronic disease, or anemia of acute illness. And it's good to have a baseline hemoglobin so you know where you're starting from. The white count. Okay, now if the white count is elevated, you think of infection. Now, there are other things that could cause an elevated white count. A patient could have CLL, CML, other hematologic problems, but overall, someone coming in the ER with an elevated white blood cell count, you think of an infection and possible sepsis. You look at the differential, and if they're bands, makes you think of infection. Okay, if there are a lot of SIGs or PMNs, more infections. Monocytes, more associated with viruses. Eosinophils, when the EOs are elevated, it might be an allergic situation. I mean, there are other things that could do that, but acutely, if somebody is an eosinophilia, you're concerned about an allergic type situation. Basophils are, I don't even want to talk about them because they're not that important for this lecture. So when you get a CBC, you need a diff. And if you're worried about sepsis, you could have a normal white count. You could have a low white count with sepsis. And if you look at the SIRS criteria, you know, it's white count greater than 12,000 or less than 4,000 or greater than 10% bands. Platelets, okay, you'd be concerned more with the low platelet count. Now, if you have a high platelet count, it could be reactive to something that's going on, like an infection or inflammation. A low platelet count you could see with sepsis, and the patient could potentially be going into DIC. And if you're worried about disseminated intravascular coagulation, say from sepsis, okay, you're going to get coags and a fibrinogen also. You're going to get more than a platelet count, and you can actually get more than coags. But the platelet count, if it's low, you might have to worry. And then there are a whole slew of things that could cause low platelet counts isolated, and the patient might present with bruising or bleeding or whatever, and you find that they're thrombocytopenic. Okay. That's the CBC. Let's talk about your chemistries. So you kind of have to match the symptoms. But if you look at the grid here, sodium, potassium, chloride, bicarb, BUN, creatinine, and glucose. Electrolytes are important. Now, hyponatremia is a very common lab abnormality in people who are admitted. And it's a long story to go through the differential of hyponatremia, the mechanisms and all that, but if somebody has a change in mental status and they're altered and their sodium's low, it might give you clues to what's going on. Potassium is important. If the potassium's low, are they on diuretics? Do they have GI losses, whatever? The bicarb is important for acid base. The glucose, if they're a diabetic, you know, or maybe they're diabetic and they don't know they're diabetic, and diabetic emergencies are not an uncommon cause for admission to the hospital, so you get a diabetic ketoacidosis, or something we used to call HHNK. It's now called HHS, hyperglycemic hyperosmotic state. BUN and creatinine will give you information about kidney function, and if they're elevated, you have to figure out, you need to know the patient's baseline, but then you need to figure out, is it pre-renal, renal, or post-renal? If the patient's septic, or if they're dehydrated, or if they're over-diuresed, their BUN and creatinine are going to be elevated. They could have acute kidney injury, be it related to sepsis or some type of toxin or something else, or they could be obstructed. but this is going to assess your renal function. Now, I always, in my opinion, everybody admitted ought to get a comprehensive metabolic profile. Okay, the other thing that's on the basic metabolic profile is the serum calcium. And there are a slew of things that cause an elevated calcium or a low calcium. Now, if somebody has a low albumin, they're going to have a low calcium. Rule of thumb, the albumin goes down by 1, the calcium will go down 0.8 and vice versa. Okay. CFP will give you your liver function test, your AST, your ALT, your ALT phos, and your bilirubin, and you also get an albumin in here. And the true liver function tests are coags and albumin and bilirubin. Okay, AST and ALT are a measure of liver inflammation. ALT phos could represent a cholestatic and obstructive process or some type of infiltrative process, as could bilirubin. A lot of things cause a low albumin. Urinalysis is often gotten. Obviously, if a patient you're worried about septic, you want to make sure you check the urine as a source. Okay, the specific gravity, if somebody's in acute renal failure, you need a urinalysis. If the specific gravity is high, they're able to concentrate the urine. It might be acute kidney injury. If you're worried, you're going to look for red cells, red cell casts, white cells, whatever. So that's important. Troponins are gotten too often, in my opinion. If you're concerned about an MI, an acute cardiac syndrome, possibly a PE for risk stratification, you're going to get a troponin. A lot of times they're ordered just because they're part of the blood work that's drawn, and then they're elevated, and you don't know what to do with it. And that's my comment about that. But the major thing with interpreting these labs, you need to match the labs to the patient. So a patient's going to come in, initially you're going to do a history. Now their patients, they're so obtunded or they're so debilitated or maybe very demented, you're not going to get much of a history. But that's the first thing you have to ask yourself, why are they here? Okay, and what labs am I going to order that's going to help make me figure out why they're here? Physical exams are important. Now, oftentimes you're not going to do a head-to-toe complete physical exam, but you're going to examine their skin turgor, they're going to look at their conjunctiva, you're going to look at their sclera, you're going to check for neck vein distension, you're clearly going to listen to the lungs, you're going to listen to the heart, you're going to examine the abdomen, you're going to check the extremities for edema, and you're going to do somewhat of a neurologic exam, which sometimes could be hard. If a patient's nonverbal and they don't understand you and they're very confused, you're not going to be able to do a great neuro exam. From there, you're going to go to the labs. So if somebody has respiratory symptoms, if they have a normal chest exam, you get a chest x-ray and you might want to get a CAT scan, but you're probably going to start off with a chest x-ray. If you feel like they're in heart failure and you hear crackles at the bases, and they've all symptoms of that, you also might get a test called a B-type NP, which measures the pressure in the heart, and that's often used in those situations. Obviously, once again, repeating this for the 4th time, it's good to know what their baseline is. Okay, that'll help you interpret them. The patient comes in and they have a hemoglobin of 10, and a month ago their hemoglobin was 14, it's telling you something's going on. Okay, they have a hemoglobin of 10 and that's what they've been running. That's another story. The white count's elevated, and one of the most common reasons for admission is some type of infection or sepsis. Then, if it's elevated, it's telling you to go look for a source of this, get source control, give antibiotics, and give IV fluids. The platelet count I talked about. If the platelet count's low and it's isolated low, you have to figure out what's doing that. The liver chemistries, there could be a problem going on with the liver and the gallbladder, and if they're abnormal, then you're going to be imaging the abdomen. And most often in the ER, they're going to be getting a CAT scan, depending on what their kidney function is. And I think I'm going to stop here. This is a quick talk on interpreting lab tests in the emergency room.